But I want to welcome you to our public hearing for the Regional Health Plan for Region 1. For those of you who haven't had a chance to meet yet, my name is Daniel DeLotte, and I'm the Executive Director of Planning here at the University of Texas Health Science Center at Tyler. And we'll talk a little bit about our role here at the Health Science Center and the roles for the region. But just to give you an idea of today's goals, we're going to be talking about the 1115 waiver background, just what the waiver is, how it works, the regional health plan development. So many of you are aware there's a very large regional health plan that will be submitted to HHS later this month. So we'll talk about how we got where we got today. And I'll have a little opportunity for some question and answers. If anything doesn't make sense or if I can explain something a little better, just feel free to let me know. And then finally, the whole purpose of today's meeting is really to receive public comment. And so for the past 6 or 8 months, the region, really over a year, but 6 or 8 months, very actively been developing the regional health plan, and we've been working with local partners across the region, hospitals and providers and different healthcare stakeholders. But of course, the public plays a critical role in this, and so we want to make sure that there's opportunities for the public to provide comment and input into the regional health plan. The presentation from today and the video will be archived on our website as we always do, so if you're interested in seeing past meetings or past presentations or even reviewing this one after it's over with, it'll be available on our website. The address is there below. A copy of the plan is also available there, as well as a previous version of the plan. So if you want to see how the plan has changed over time, you're welcome to do that as well.
So let's get started with what the waiver is just in general. A waiver is simply an agreement between the state and federal government on operation of the state's Medicaid program in a way that's different from the standard program requirements. And so we'll talk about this here in a little bit, but the waiver itself is not limited to the Medicaid population. The waiver is a much broader application, but it's found within the state and the federal government's Medicaid laws. Waivers have been used widely to address statewide challenges in healthcare delivery and to demonstrate innovations in Medicaid. And so we see these waivers around the country. There's about 500 waivers that are active today around the country. There's several active in Texas, and so you may hear of other waivers that are also floating around, but this particular one deals with healthcare delivery system reform. And then I always get the question, I never used to add this in the presentations, but I always get the question of where did the 1115 come from? And it's really just because it's section 1115 of the Social Security Act of federal law that we get the 1115 waiver. There's other sections of waivers. There's a 1915 waiver, but this is the 1115 section. So this particular waiver is called the Texas Healthcare Transformation and Quality Improvement Program, and it was approved in December of 2011 as a 5-year demonstration waiver. And so we will run through 2016 and we'll talk about what those years look like as we move forward. But eligible entities, in a very broad sense, eligible entities can see under 2 pools. The first is for uncompensated care, and the second is for delivery system reform incentive payments, or what we call DSRIP. So for uncompensated care, that's fairly straightforward. It's the cost to provide care to Medicaid eligibles, dual eligibles, and those who have no other source of payment for health care. We're not going to spend a lot of time talking about uncompensated care today because the bulk of the regional health plan is focused on these delivery system reform projects, and I want to spend most of our time talking about that. But just have in your mind to realize that there's this other section of the waiver that really isn't discussed at a great length today. Funding under both pools, whether it's uncompensated care or DSRIP, requires a governmental entity to transfer what's called a state match to fund the state's portion of these waiver payments, and we can talk a little bit more about that if you have some questions. But just to know that this is a state-federal partnership, and there are local governments and state governments participating in the waiver as well. And then finally, it is not limited to the Medicaid population. We have talked about that it's an 1115 Medicaid waiver, but it's not limited to the Medicaid population. So you'll see projects as we talk today. If you've read the regional health plan or reviewed it, you'll see that these projects address a wide variety of healthcare challenges across broad populations, but they definitely have an impact on the Medicaid and indigent population. So the waiver goals at a very high level are one, to place decisions regarding healthcare delivery system improvements in the hands of local stakeholders, you that are here in this room. And that's why we engage the public, that's why we engage our local hospital partners, and that's why we spend a lot of time around the region developing ideas and concepts from stakeholders across the region. It's to help drive down the cost of uncompensated care. And so obviously, if you've read the papers and followed the news on this, that obviously uncompensated care is very expensive to healthcare providers, and so we want to look at ways that we can reduce that cost. We want to achieve accountability and transparency in this funding system, so there's a lot of money that's going into healthcare in Texas and in Northeast Texas in particular, and so we want to improve the accountability and the transparency of that.
And really, as a region, this last little bullet point is really the overarching regional goal, is to develop a coordinated regional health plan that improves our quality of care, improves the health of the populations that we serve, and reduces the cost of care across the region. So we talk about the triple aim, quality, cost, and health. Those are the things that we're looking at. And so the waiver was approved in 2011, and the first thing the state did was divide the state up into 20 regions across the state and said these are going to be called regional healthcare partnerships, and those regions are going to be responsible for developing a regional health plan that effectively and efficiently delivers care and provides increased access to care to populations. And so I'll highlight Region 1 up in this little corner here. 28 counties, we have 1.2 million people, 21,000 square miles, but no city larger than 100,000. And so it's a very rural population. We're larger than 8 states. So it's a very large area of Texas, but it's a very rural area. And so we have access problems that are different than maybe our neighbors in Dallas or Houston that have metropolitan access problems. So we'll talk a little bit about that here in a minute, but just to give you some perspective on how the region is broken up. And so once we had regions established, the main deliverable, what those regions are expected to do is develop a regional health plan. And so a regional health plan in a very broad way is simply a plan to identify the community needs, the projects and investments under the waiver to address those needs, and the partners, challenges, and quality objectives of the region. And so you'll hear me use the word region a lot. These are very regional. These are collaborative. They are intended to redesign the region as a whole, not simply one institution, but to look at the region as a coordinated group of healthcare stakeholders. And then they said, well, we need somebody to organize this whole thing, and it's a big project, and so we need one single institution that's responsible for developing the plan, organizing the region, and we're going to call that entity an anchor. And it's the single entity in a region that's the primary coordinator for the partnership and development of the regional health plan. In Region 1, that is our institution, the University of Texas Health Science Center Tyler, and so we're very honored to play in that role in partnership with our stakeholders in the region. And so I want to just show you this for those that maybe haven't attended one of our meetings before. There's a lot of different people involved in the waiver, and so this is a summary of some of the large groups of people that are involved. I talked earlier about the anchor institution, that's us. IGT contributors are those public entities in the region that contribute dollars that help fund the waiver. We obviously have healthcare providers that are involved in the waiver. Hospitals are a key part of the waiver, and I have those separated because hospitals are one group of healthcare providers, but we have other healthcare providers out there who are not hospitals that are major players in the waiver. Local mental health departments, a number of people that are involved there, and then other stakeholders. There's a broad group of people who are involved and have a reason to be involved in the waiver, and so we have that sort of categorized there. But just to show you, this is a coordinated effort. They're all connected. All of those together are called is the Regional Healthcare Partnership, and certainly the public plays a major role in what we do. Just as a summary for Region 1, here's who's participating as a performing provider. And when we use the word performing provider, we mean a very specific thing in the waiver. A performing provider is a healthcare institution that is eligible to receive a direct waiver payment under the waiver. And it's very limited. It's a hospital, it's a local mental health authority, it's a public health department. In some cases, it's a physician group. Other people can participate in collaboration with those entities, but those are the only entities that are eligible to be the single entity accountable for that project itself. And so in Region 1, you see up here the people that are involved. We have 5 local mental health authorities, 8 public hospitals, 10 private hospitals, 1 academic health science center, 2 local public health departments, and 2 physician groups that are participating in the waiver. And as I mentioned, we have a number of collaborations in the region that involve other partners, whether it be an FQHC, any other kind of entities, but that are collaborating on projects to accomplish those projects. And so once the region was divided up and we sort of knew who the players were and knew who the providers in the region were going to be, we began to do a community needs assessment, because part of the waiver's requirement is that you look at what are the healthcare challenges in your region, what does the data and the evidence say your region needs from a healthcare standpoint, and report that. So we developed a community needs assessment, and I won't summarize it here. It's about 20 pages long of very strong data, but I'll just point out the very first bullet point here is that over half of the counties in Region 1 are in the bottom quartile of health outcomes in the state. And so we know that in Northeast Texas we have significant healthcare challenges that need to be addressed. And in fact, our challenge in the community needs assessment wasn't finding the need in the community. It was trying to condense this down to what are the major priority needs in the community. So through that process and talking with our local stakeholders, talking with county officials, talking with hospitals and healthcare providers, engaging the public, we identified 6 healthcare challenges that the best evidence suggests Northeast Texas needs to address. And so these are the 6. There's a few bulleted, and I'll explain why those are bolded, but primary and specialty care access, behavioral health access, chronic disease management, potentially preventable hospitalizations, and we could talk, there's a lot of data out there that shows how expensive potentially preventable hospitalizations are, and so we want to address those in the region. Emergency department utilization, and then just the efficiency and effectiveness of our delivery system. I've bolded primary and specialty access, behavioral health access, and emergency department utilization because these tend to be the areas that our region clearly focuses on addressing. These tend to be the major challenges that we face in the region, and so I want to highlight those 3. Not that the other 3 aren't important, but that the most of our projects tend to be in one of those areas of the community needs assessment. And so what do you do with this community needs once you get it? Well, under the waiver, we talked earlier about these desert projects. The idea behind a desert project, so these are projects to enhance the access to care, improve the quality of care, improve cost effectiveness, we talked about that with the triple aim, and improve the health of patients that are served. These projects are the solutions or the things that healthcare providers think will actually help address those community needs that we talked about. They must be evidence-based. So your project has to be an evidence-based project. It has to be based in medical literature. It's got to be selected from an approved menu of options. And so that menu was developed by physicians across the state that looked at all the challenges the state of Texas had as a whole and what did the best evidence suggest were the ways to address those. And so that menu was published and providers select from that menu, and your projects have to have outcomes that are measurable. They've got to be time-bound because, again, it's a 5-year waiver, so the projects that are included in the regional health plan have to be accomplishable within that time period, and they have to have an impact on the health of a population. So it's not enough to just impact a very small group of people. We're trying to impact and improve the health of the population across the region. And then obviously, from a regional standpoint, I mentioned there's 20 regions. So all 20 regions are working towards similar goals, and all 20 regions are working with similar projects. And so when we roll all this up into a statewide health plan, we ought to see the health of the state's population improve. We ought to see the numbers of chronic diseases maybe decrease. How we're managing those outside the hospital settings should be increasing. So just in a broad sense, desert projects are projects that are designed to really move the needle on healthcare challenges in the region and in the state as a whole. And so in Region 1, we'll talk a little bit about how the projects that were developed were selected. And so for the past almost a year, providers have been looking at different challenges in their communities and different possible solutions. Those proposed projects were scored through a tool used, modified from the National Institutes of Health. It's an evidence-based tool that's used to score projects across the country, and we thought it was really applicable to what we were doing here in the region. The scoring tool assessed the strength of a project across 5 domains, and I'll mention them and then I'll talk a little bit about a couple of them. Alignment with the community needs, transformational impact, integration, and then what we like to call the likelihood of success and your sustainability of the project. And I'll say, for a project to be included in the regional health plan, it obviously had to have a direct link to the community needs. So you couldn't do a project if it didn't have an obvious evidence-based need in the community for that project. So that was a critical element in the scoring tool. But the next 2 are really important, transformational impact and integration. We talked a lot about in regional meetings and in collaboration sessions with our partners that your project really needed to be transformational. It needed to do something different. It needed to really improve the population in a significant way. And so that particular item was weighted heavily in the scoring tool, because if you had a project that was aligned with the community needs, but it really didn't do much, it wasn't going to be scored very high because it didn't have a very large transformational impact. And the other one that I'll talk about is integration, which was also weighted fairly heavily. And it's the idea that your project isn't just yours, that there's multiple stakeholders involved in your project. If you're a hospital, you've reached out to other partners and you're working with them to develop the project and to implement the project. And you're doing this really in a big tent way, that you're involving as many people as you possibly can to coordinate this care across a large area. So those three areas were the three domains that were weighted the heaviest in the project scoring tool, and for obvious reasons. Obviously, likelihood of success, we want a project that's likely to be successful, but and then sustainable. You know, a project that can continue to go on and improve the healthcare of the community after the waiver is over. Using that process, we said, look, the most transformative and beneficial projects are now selected, and we're going to include those in the regional health plan. And when I say we, I don't mean we as the university. I mean we as stakeholders and as the healthcare partnership included those in the regional health plan. And so here's the numbers on it. Overall, we looked at 184 different projects for inclusion in the regional health plan, but fewer than half were actually included in the plan. And by far, the most common reason for not being included in the plan was that the project had a low score on that project scoring tool. And so the tool worked as it was intended to do. It looked at only those projects that were the most beneficial. So we had 184 projects that were considered by the Regional Healthcare Partnership. 90 were accepted and are included in the plan. The next three things, Pass 1, Pass 2, and Pass 3, are just the different rounds that projects could be submitted in. And so you see the vast majority were submitted in Pass 1. And then it got smaller and smaller as we moved on. But the acceptance rate of projects was about 48%. So just a high-level summary of projects. It's impossible for me to sort of summarize 1,200 pages of projects in this meeting, but just in a very broad sense, the clear focus in the region is on improving access to primary and specialty care and in behavioral health. I mentioned emergency department room utilization, which is often very clearly linked to these two areas. But really the focus has been on access to primary specialty care and behavioral health. Many of the hospitals are working on emergency department use, and we see a lot of collaboration in the region, not just on behavioral health and these elements, but on a number of other projects. And then one other item that's really pretty important in terms of the waiver and in terms of continuing this progress across the region is that providers will participate in something called a learning collaborative. And so over the next 4 or 5 years, a few times a year, the region will get together and share best practices and look at lessons that have been learned in implementing these projects. And if there's a particular method that works really well with a particular population of patients, we'll share that with the region so that other healthcare providers can benefit from that across the region. And so we've been very pleased with our providers' willingness to share this kind of data and information across the region to really improve healthcare for everybody, whether you're participating in the waiver or you're not. And so we're not done with the review phase. What you see in the regional health plan is the regional level review and submission, but there's several others. And so we'll talk about the regional review first. We talked about the project scoring tool that was used to get them even in the plan. But then beyond that, once they were included in the plan, we did a review to ensure they met the waiver requirements. And for those providers in the room, you know that's a significant list of requirements that had to be met for your projects. And so we did a review. We also had an external quality reviewer look at each individual project and provide feedback to providers on those projects so that they could strengthen the quality side of their projects. Those reviews are done, and so if the regional health plan that you look at today is the full final regional health plan that will be submitted to the state no later than December 31. When that is submitted to HHSC at the state level, they will then review every project in the plan for the technical aspects of the waiver, but also the quality side of the projects to ensure that they actually are high quality, high impact projects. Once the state has reviewed it and certified that every project in the plan meets their requirements and is a quality project, it'll go to the federal government for review. And so the Centers for Medicare and Medicaid Services will review every project again for those technical and the quality aspects. So these are highly reviewed, highly vetted projects that have been vetted in at least these three ways, but they've been vetted even before they reach the regional health plan, as we talked about it earlier. Just a brief overview of the work that's been done across the region. I can speak to obviously the things that we as the anchor have done across the region, but every individual provider I know has spent considerable amount of time in their own communities visiting with their local public stakeholders, their physician groups, their hospital teams, their stakeholders to make sure that these projects have as broad of stakeholder impact and engagement as possible. From an anchor level, we've conducted about 36 public outreach activities in over 15 communities across the region. So we've tried to get out of Tyler and go see folks in the region and try to explain how the waiver works, how they can be engaged in the waiver, and discuss the progress of the regional health plan as it's been developed. All the meetings and activities of our regional healthcare partnership have been open to the public, and they've included meetings and weekly webinars, and we've posted those video and PowerPoint presentations online for folks to look at if they weren't able to attend. We recognize in a rural area like ours, it's sometimes hard to get across the region, especially when it's 250 miles from point to point in our region. So we've tried to use the internet and use other technology to make this more available to folks. And then the regional health plan itself was posted online, distributed by our regional public health director for the Department of State Health Services, and we placed notices in newspapers across the region to alert the public of developments in the waiver as well. We've had 2 public comment periods for the regional health plan. The first was in early November to look at the phase 1 of the regional health plan, and then as providers did additional work and the full and final plan was developed, the second public comment period was actually this week, December 17th to the 21st. Each public comment period included a public hearing just like this, and so obviously we're holding a public hearing today. There was a public hearing held on November 9th where we received public comment. And folks who have interested parties can provide comment in a number of ways. One, you can submit a public comment form that's available on our website. It's also available with the regional health plan. Or you could attend a public hearing and just make verbal comments, and we make sure those are recorded and provided to our stakeholders. We also, as an anchor, respond in writing to every public comment that is submitted to us, either over the internet, through our public comment form, or in a public meeting like this. We make sure that those are responded to in writing, and we post a summary of those public comments and the responses online so that other stakeholders and members of the public can see those. I'll also add, in addition to this, every day we send an update to all of our providers, our hospitals and mental health authorities and those folks. We send them an update every day of the public comment that's been received every day so that they can be updating their plans based on public feedback and public comment. And so it's an ongoing and a fluid process. It's stressful for our providers because they're making edits on the fly and then emailing us things as they come. But we wanted to make sure that those public comments have been as useful and to providers as possible. And then, of course, we're here today for the public comment. And so we just ran through a very complicated process and a regional health plan that is about 500,000 words very, very quickly. And so I want to pause for a minute and just answer any questions that I can about this presentation or anything else in the regional health plan that maybe I can help resolve. I know that was very fast. Sometimes there's some things that we skimmed over that you may want a little more detail about, and I'm happy to answer that. So are there any questions that I can try to address? Yes, sir.
Daniel, I just wanted to thank you and congratulate you and your team for, I think, doing a very good job in managing the anchor activities here. One of the things I wanted to do is ensure that it be done in a very fair and equitable way across the entire region, and the feedback I've gotten is that the providers really feel that way as well as the IGT participants. So very good job there. Second comment is last week I was in Washington and had a chance to meet with Cindy Mann, who's the director of Medicare and Medicaid services. They are obviously very interested in the Texas waiver. There are half dozen other states that are lined up wishing to pursue similar waivers. California was an early model. We're a later model. They've been much tougher with us than they were with California initially. They're going to circle back to them on some of these issues, but I think we can expect quite a bit of scrutiny. And she's particularly interested in Northeast Texas because of some of the health statistics that we had an opportunity to share. That's one hand of the equation. The other hand of the equation is that they not only have to handle this waiver and the reams of paper that they're going to receive from Texas, keep in mind that they have to open up exchanges, maybe in as many as a dozen states around the country, because their governors or state legislatures are not going to do state exchanges under the Affordable Care Act. And the feds have to come in and set up those exchanges. They'll probably use outside help. But it is a tremendous task, and both I and both myself and others believe that they're going to be in for a really hard time being able to review all this data and then run around and be opening up healthcare exchanges across the country. So if there are further delays in all of this and delays in us getting our money, I think you better expect that and be prepared to deal with that and just be patient and not get frustrated if you hear that they're not going to be able to meet their deadlines. I think there's a high likelihood, I mean, they can't fix the fiscal cliff in time. So I think there's a high likelihood that deadlines are going to be missed.
Thank you very much. Appreciate that. Any questions? Yes, ma'am.
Yeah, so as you know, I submitted a Pass 3 project, and one aspect of that is trying to get access to specialty services, and I think there might be other projects within our region that are trying to deal with that, like can you bill for remote telephone consultation or remote televideo, or how does that work? I'm just wondering, is there a network for us to collaborate and communicate on issues that might be common to several projects, particularly because it deal with access to specialty services?
Yeah, so the question, just in case you didn't hear it, and certainly for the video, was whether there's a number of projects out there that look to improve specialty care access, and is there a network for those providers that are doing similar projects to collaborate with each other and talk about ways to improve that? I would say a couple things. One would be the learning collaboratives that are going to happen on a regular basis throughout the region are going to be the perfect opportunity for everybody to get together and share, this is the challenge I'm facing in this project, and maybe another provider has found a really good solution to that, and we can share that information around. The second thing I would say would be to continue to utilize our weekly webinars and other technology that we use, whether it be email or those kind of things, to share things. We're going to shift gears here pretty quick from project development and the regional health plan development to assisting stakeholders in being successful in their projects, because the region as a whole has a stake in everybody's individual projects being successful. And so I envision that our ongoing efforts with providers and the public will be focused on how do we take what we've said we were going to do and help the region be successful and the population health be improved. So I think you're going to see a lot of opportunities in the coming months to do that as you're getting into your projects. The other thing that I'd point out is many of the projects, the first sort of reporting period is primarily a planning phase. So the first few months is planning the project and getting an operational plan put in place. And I think if providers may be willing to talk in that early stage, we'll have a learning collaborative just to talk about some of the roadblocks that hit there. So I think that maybe on the front end, as you get into things, you can maybe hit some, try to get some things dealt with there. And we're going to use some technology through NetNet and those video conferencing abilities that we have around the region to connect providers together to have those conversations. And as an anchor, we're happy to facilitate other meetings if those are necessary. I know during the project planning phase, the plan development, we noticed that a lot of our providers were working on behavioral health projects and really needed an opportunity to have some collaborative work sessions with those. And so we actually held 3 different work sessions on behavioral health with providers so that exact thing could happen. And so we're certainly happy to do that. Just let us know and we'll coordinate with providers and try to get a work session put together if there's enough issues going on in the region that needs to have that happen. Yes, ma'am.
Daniel, I just wanted to say I appreciated the bullet point on there about populations being served, because there have been a lot of questions about how do you maintain the same level of service for all populations. And this is almost in reverse, because for many of us, it's important to try to make sure, regardless of the payer, they receive the same level of care and the same access. Now, in reverse, the question's been asked, wait a minute, is this only for Medicaid populations, and how would I carve that out of my practice? So I think making it clear that it serves all populations, but certainly targeting an emphasis on Medicaid is very helpful.
Yep. Thank you very much. Yes, sir.
Just as a follow-up to the commentary you're making about the learning collaboratives in response to Dr. Sherry's question, and that is that the anchor is being very generous in supporting the development of a Northeast Texas Center for Rural Community Health that can be the facilitator or repository for these learning collaboratives. That is in development, it is evolved, and of course has awaited the delivery of the regional health plan so it can begin to actually do its work. But that will be unfolded in the coming months.
Right, and so just for the video. I always remember I'm the only one that has a mic on right now, so I have to make sure I repeat things. But there will be the Northeast Texas Center for Rural Community Health established that will help facilitate a lot of these collaboratives that are happening, and also serve as a clearinghouse for best practices across the region. So to the extent that there needs to be a central location for the posting of papers or articles that describe effective ways to accomplish things under the waiver, certainly that center would be an excellent place for that. It'd be housed here on our campus and be a really great resource to folks. There will be other learning collaboratives that happen around the region with groups of providers, but certainly we'll facilitate as much as we can and be a part of as many of those as we can, just to help keep a cohesive regional structure moving. So.
And Daniel,
Yes, ma'am.
one of the things that we looked at on those learning collaboratives, because some of our projects that we're doing at Mother Francis are not necessarily being done by very many other providers out there, cost containment and
Yep.
transition of care. And so while we put in our project that we would be the lead for developing those, our concept was that we would be doing it in collaboration with Riddles and others. So
Great.
I think that's one of the things that we hope to be able to access and show collaboration.
Absolutely.
Is to access that point too.
Absolutely. Absolutely. Any other questions? Did you have a question, or just rest in your arm? Yes, ma'am.
Yeah, I have a question.
Sure.
You mentioned like 8 public hospitals, 10 private hospitals. Is there a listing of who's involved? Is it in essence creating its own network, and so these are the providers for this program and no one else is, or what is that like?
Yeah, so the question was, we mentioned, and I have it up on the slide now, the different providers that are participating in the waiver. Is there a place where you can find a list of all that, and are those providers now just their own network? So yes, there is a list of this online. If you go to our website, uthct.edu/waiver, click on the proposed Region 1 health plan, and in Section 1 there's a table that shows all the providers that are participating, broken up into different sections. But you probably want to go to the performing provider section of that table. It'll list every one of the providers that's participating as a performing provider and the contact information for those providers. They are not a network. It is simply, so the best way to describe the regional health plan is that we stand alone and we stand together, because each individual project is implemented by a single performing provider, but the region as a whole is implementing a regional health plan. And so each individual project feeds into a very large coordinated effort to transform how we deliver healthcare in Northeast Texas. So you sort of view it that way. It's not a special network that you have to gain entry into to do any kind of work with. Many of these, I'll say, as I mentioned earlier, there's a very defined group of people under the waiver. This was part of the policy that was agreed to by the federal and the state governments on who would be a performing provider. And those, again, are just the single entities that are responsible for carrying out the project. It doesn't mean they're the only ones that can participate in the project. It's just whose name is on the bottom of that, on the bottom line, responsible for everything that happens in the waiver. I expect that the vast majority of these people you see will have subcontracting relationships with other healthcare providers across the region, whether that's home health in your instance, an FQHC, other providers they need to have participation with. There's going to be a lot of collaborative efforts going on that aren't reflected just by these numbers of providers. This, again, just looks at the performing provider section. But there's nothing special an entity has to do to engage with one of these providers in one of their projects. And so what I've suggested to folks in the past is, so Section 1 has the table of all the performing providers. Section 2 of the Regional Health Plan has a table of all the projects. And so every project is very, very briefly, there's a brief description. It'll tell you who the provider of that project is, what the goal of the project is, how they're measuring their outcome. And what I've said to folks is, if you see yourself being a partner in that project, you see that you have something that you could offer to that provider, or you want to collaborate with them on that project, give them a call and say, I've looked at this project and we may be able to help you on that. We're interested in collaborating with you on that, and discuss that with that local provider. And there's a lot of that happening around the region. So I would encourage you to continue to do that. The full plans are also in that full document. So if you want to look at every plan, this is just sort of a mechanical explanation, but in that table in Section 2, you're going to see a long string of numbers right in the far left-hand corner. if you search for that long string of numbers, if you find a project in that table that you want to read more about, if you search for that long string of numbers, it'll take you straight to that whole project, and you can read the full project and what the goals are, what the 4-year plan is, how it's going to be accomplished, all those kind of things. And so hopefully it's a searchable document, so I hope we tried to make a 1,200-page document as user-friendly as possible, but I recognize that's a big task. So does that help? Okay. Yes, sir.
Daniel, quick question. In terms of operationalizing this particular plan, there's a lot of things that need to happen. Say suppose you meet your metrics for year 2, year 3, then you don't meet your metrics for year 4, and somebody decides to put that particular project because they're not able to meet the metrics of year 5. What's going to happen at that particular level for this particular regional plan as a whole?
Okay, so the question was, these are very complicated projects to implement. There's a lot of moving parts involved, and so if you get, and I mentioned earlier, there's very specific metrics and milestones you have to meet. So what happens if you get to the 4th year and you can't meet those metrics and you've got to pull the project? What happens at that point? Are you asking at a regional level what happens to the regional health plan? Well, there's, as you know, in the protocols that set out the rules and requirements for the waiver, there are some opportunities for partial credit for partially meeting your milestones, and there also is a little bit of an opportunity for you to meet them in the next plan year if you have to, just to continue the project moving forward. But ultimately, if you get to a point where you can no longer meet the requirements of the waiver, I mean, you won't get paid on the project, essentially, is the ramifications for the provider. Provider won't receive any waiver payments for that project. The region continues to move forward. So there's other projects in the region that are moving forward that will continue to happen. And I think as a region, through the Learning Collaborative Network and those other opportunities to collaborate together, I imagine regional stakeholders will be offering assistance or trying to figure out, is it a best practice? Is there somebody doing a similar project? They've learned a way to resolve the specific problem you're having. Is it just a project problem, at the local level? I think we'll take those as they come to see if we can provide assistance to folks. But generally speaking, the region will move forward, and your project, you just won't be eligible for waiver payment for missing those targets. The targets are what triggers that waiver payment. Any other questions? Yes, ma'am.
Daniel, in regards to Dr. Calvin's comment about potential for delay in startup of this project, since we are edging up 3 months, soon to be 6 months before we know it, in the DLI 2, I would just say I would hope that everybody would recognize that as a good faith effort by all of the performing providers out there, that many of us have made the decision not to wait until final approval by all the entities out there, because waiting clearly negates the opportunity to maximize the impact for the patients that these projects were devised for. And so I think many of us have made the decision to invest a considerable amount of dollars to go ahead and begin that planning process, and because, as you said, many of them are recruitment positions, primary care and specialty care. Those dollars are already being spent and committed out there with the intent that projects were submitted in good faith, that they would meet or be able to be negotiated with the state and the federal government to meet those criteria.
Yeah, and so I'll paraphrase very quickly in 2 sentences what Mary Elizabeth so eloquently said, but the challenge is we are a few months into the first implementation year, and so many providers have chosen to go ahead and begin to implement projects because there's just not enough time to wait on final approval to get the kind of impact on the population that they want to get out of these projects. And so many of the providers are taking that risk now to go ahead and begin that work and laying the groundwork and doing waiver activities so that they can impact populations. And so that's definitely right. There is a balance right now with providers of, we're technically in implementation year, but we don't have final approval. So each provider is having to make those decisions about how far do they want to implement the project prior to that. And that's, I certainly commend folks that are doing that. I know most providers, I think, are doing that because there's just not enough time to wait to achieve the kind of results that we're hoping to achieve with the waiver. Yes, sir.
As a follow-up comment, I think most of us have consultants, legal, region, the anchor, or they have an opportunity to provide any legal consultation or direction? Because we were thinking about some of the same things in terms of accusation. However, if our stakeholders put dollars forth on something like that, do we run the risk of it becoming an ineligible contribution or donation?
Right.
And we've got a team of that, but I was wondering, is anything being done on a regional level so we might be able to all learn from that?
So the question was whether, I think there was two questions built into that. So the first seemed to be whether the anchor at any level was going to provide some legal guidance or some other kind of advice on when to start a project or not and the relative risks of those. And the second seemed to be whether there was going to be a regional discussion about those kind of issues, about where folks were going and those. The first I will say is no. The anchor, I would say that the best thing for you to do is to discuss that with your legal counsel and somebody that you're discussing your unique situation with. We certainly can't provide legal advice. First of all, I'm not a lawyer, so that's one of the reasons I can't provide you legal advice. But the second is that those are going to be so specific to your institution, it's going to be difficult for anybody at the anchor level to really provide that kind of a in-depth guidance. I would say a couple things we can do. One, we'll certainly relay whatever we hear from HHSC and CMS to you as quickly as we get it. And from time to time, those issues come up on the anchor calls or on other discussions with HHSC about, challenges of implementation. And I think there'll be opportunities for us to provide you some feedback based on federal or state guidance on those issues. Second is, I think those, again, are questions that are ripe for a learning collaborative, for folks to sit around the table and say, this is what we're seeing work best for us on just even beginning the implementation. And so we'll certainly provide a venue and a forum for those discussions. But in terms of providing you, legal advice, that's really, unfortunately, not the role of the anchor. Fortunately for me, it's not my role that I have to worry about providing you legal advice. But I would say continue those discussions you're having. And because it's going to be a risk decision you make at your local level, you need to be comfortable with your own legal counsel on that.
Well, and I think most of us do have legal
Yeah.
teams. And I think given the question here, it becomes really important because we have a private hospital that wants to then assist in the implementation of the project early before implementation. I think there's a real
Right.
risk there of it becoming questionable in terms of the donation component to that. So probably some of us do need to get together and just kind of have a
Just have that discussion with some providers. I think that's the best thing for that. Okay, I don't see a whole lot of questions. I see one more. Yes, ma'am.
Our plan is going to be submitted to HHSC by no later than December, that's the deadline.
Right.
And then HHSC is going to take 30 days.
Yep. So we'll
Review.
kind of go back to this review phase. So we'll submit our plan no later than December 31. I'm actually on target now of December 28th, so I'm kind of excited about the extra weekend that you buy yourself 2 days. It's pretty exciting. The state review will be a 30-day review, and we're hoping they're able to accomplish that within 30 days. The federal review is a 45-day review, and just keying off of what Dr. Calhoun said and others have said on the delays. So that 30-day window of time is important, but if there are changes that are necessary to a plan as a result of that review, that delays when the plan even goes to the federal government for their review. So there's going to be some timelines within there that providers and other stakeholders have to look at it and say, I've got to get these project reviews back into the state for them to look at and make sure that the changes are good before it goes to the federal government. And even at the CMS level, they're going to be working with providers back and forth on improving plans and strengthening them. As a region, we welcome that and we expect that. And so we're looking forward to that opportunity. But just so that folks understand, this may delay the overall time that you have to get your plans finally approved at the final level. So just have that in your mind that we are talking about sort of a rolling time period here, and that also factors into the comments that people have made about when do I actually implement something. I think you should get more and more comfortable through the review periods, right? If it gets to the state level and the state's looked over them, and we've already had several periods of state review. For those for our public guests today, we've had a preliminary feedback, we've had immediate guidance from HHSC, we've had a number of things that have come in already on plans to help people strengthen them prior to submission. And so that's all intended to try to speed up the review process. So with that, I want to make sure we have time for public comment. Our basic process has always been somewhat informal for this, and so if anybody has a comment they would like to make as public comment, and again, this is comment that we will include in the regional health plan and we will respond to in writing to you, just let me know and we'll make sure to get a mic over to you and we'll get you on the tape so that we can get that written down and make sure it's recorded. But are there anybody in here who would like to make a public comment? We'll have to steal my mic, he's telling me, if you do, so we'll let you talk into my tie. So I don't see any. So that'll save us from having to shift mics. But thank you all very much for being here and for participating. For the providers in the room, thank you for your hard work over the last few months. And for our public guests, certainly appreciate your involvement and engagement in this. I'll end like I always do. This is how to get a hold of me if you have any questions at all. Whether you're a provider or you're a member of the public, I am happy to take your call. Your email. Those of you that have worked with me over the past few months know that I rarely sleep, so if you email me at 1 in the morning, you're likely to get a response back about 2. So feel free to email me, call me. There's our website. You're welcome to go to that, review the plans. You can review past meetings. This will be posted as soon as we can, but with the Christmas holiday coming up, we may have some folks in and out, but I'm getting the wave that he may have it today, so that'll be wonderful. So you're welcome to look at that anytime you need, and just call me anytime we can be of help. So thank you all very much. Appreciate it.